Hello, 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 and welcome back to the IBS Freedom Podcast. I am delighted to report that we are joined by a special guest, and we're going to talk all about endometriosis. Buckle up, ladies. It's going to be a good episode. We are joined by endo.fertility.dietitian. I had to have this open in my window so I would not forget your proper Instagram handle, aka Cindy Dabrowska. Welcome to the IBS Freedom Podcast.
You're so funny, Nicole.
Yay! That's probably the word.
No, I love it. It's so entertaining. I'm happy to be here and always happy to talk about endo. I think we need as much info, as much, what's the word I'm looking for, awareness as we can get for the condition. So happy to chat about it.
Yeah. Because I think there's probably a fair margin of women who have been told that they have IBS when they, in fact, have endometriosis. Would you agree with that?
Absolutely. 100%. In fact, I just had somebody reach out to me for a call, and right in there it said the doctor suspected IBS, but her symptoms are so characteristic of endometriosis. So absolutely. I think the statistic is like something like 90% of women with endo have some kind of GI symptoms. So a massive overlap there for sure.
Makes sense. And do you, not to totally put you on the spot, but do you know, like numbers wise, about how many women are affected by endometriosis? So we could give people some sense of like how common this is.
Yeah. You know, Nicole, the statistic right now is about 1 in 10. But I predict it's a lot more than that. We're normalizing period pain so much. And just with the way that the world is changing, the way our food supply is changing, I suspect that it's probably a lot more than that. But that's just my guess. Yeah.
Even that's super common, though. Like 1 out of every 10, if you think about, you know, like your homeroom in high school.
Right.
And there's, you know, if there's like 30 kids in your homeroom, that means that at least one of the girls in that class is going to have endometriosis. And there's some likelihood that maybe 2 of them would have endometriosis.
Exactly. And, you know, there is such a thing as silent endo. So, you know, women with endo who have no characteristic like pain symptoms or GI symptoms related to endo. And then they only discover that they have endo after they've gone through fertility treatments or surgery because they haven't been able to conceive. And so there's this whole other, you know, space, this whole other demographic where, you know, how many of them are actually getting surgery and confirming this, right? So I suspect it's significantly more than 1 in 10. That's just my prediction.
That's so interesting too. I am currently pregnant, and so like the fertility side of the equation is so interesting to me. And it seems like nowadays there's so much infertility stuff happening. Like it seems to be way more common than it did in the past. And again, it's not to say there weren't infertility problems in the past, but it just, you know, a lot of my friends that I talk to are having trouble or struggling a bit. And I wonder, you know, what percentage of those people have ruled out something like endo, and again, how much that could be playing into the equation. And there's multi equations with infertility. There's a lot of different factors to consider, but it's really interesting that, you know, you're saying that it might be a higher prevalence than even 1 in 10.
I would put money on it.
Yeah.
You know, for a combination of reasons. I mean, again, we're being exposed to more and more chemicals. We know that there is a connection between some chemicals like dioxins and parabens and things like nickel, for example, in endometriosis. The food supply, you know, it's changing. We know that there's a genetic link. Yeah, like, I mean, even just from my you know, group of friends, one of our close friends, they had been trying to conceive for 3 years, and she had no indication that she may have endo. But because they were trying to conceive and they had access to a surgeon and a doctor who was supporting them, you know, very comprehensively, she was able to get some surgery, and it showed that she had endo, right? Mild, but Like somebody like that would never know that they have endo unless they, they had a doctor or a surgeon that was willing to investigate further. So I predict it's significantly more than 1 in 10 for sure. Yeah.
And I'm curious, like I want to talk about what some of the symptoms are of endometriosis and like what would tip somebody off that they need to get tested and what the testing process looks like. But first, I'm just curious, do you have any hunches or understanding of why some women would be largely asymptomatic, but others would have symptoms? Do you think it has to do with the size of the endometrial lesions, the location of them? Also, can we backtrack and can you just explain for the listeners what endometriosis is? We have this bad habit on this damn podcast where we will get like an hour into the podcast and then we'll be like, oh, we should define the thing that we just talked about for an hour. So can you do that first and just tell people what we're talking about and then answer my actual question?
Absolutely, yeah. So endometriosis is a benign gynecological condition that's inflammatory in nature. So the way that it's described typically, online or on social media is that tissue that's similar but not identical to that which lines the uterus grows in other parts of the body. So at this point, it's been found all over the body. There's no organ on which endometriosis hasn't been found. And it responds to the same sort of, hormonal changes in the menstrual cycle. And so when the body prepares for menstruation, this tissue responds to that change in the hormones. And it bleeds much the same way the uterine lining would. But the problem is that it doesn't have anywhere to go since it's not within the uterus. And so it bleeds, wherever it's located in the body, and then it forms scar tissue. It causes a lot of, extremely excruciating pain. It causes organs to adhere to one another. And I can definitely get into that long list of symptoms. So the one that would tip somebody off that they may have endometriosis is that debilitating pain, right? So pain that is really impacting activities of daily living. You're not able to go to work or school or socialize like a quote unquote normal person. Extremely heavy, clotty bleeding. A lot of typical estrogen dominant symptoms, which, you can experience whether you have endometriosis or not. Like the breast tenderness, the heavy, clotty bleeding, mood changes, headaches, like cyclical headaches. Weight gain in the waist, the thighs, lower back, things like this. Those are characteristic as well in endometriosis. A lot of GI symptoms, so it could be chronic loose stools, chronic constipation, extreme severe bloating. Infertility is a huge one as well, so trouble conceiving. And I'm always mindful on podcasts to include sort of the indirect symptoms as well of endometriosis. So, when you're living in chronic pain and it's affecting your ability to socialize, have relationships, go to work and school, this is going to impact your mental health as well, right? So I'm always mindful to bring this up. So depression, anxiety, there's lots of research showing that it's a really big range. So I don't know if they have any better research on this at this point, but anywhere from about 25 to, I would say 75% of people with endo have some degree of depression or anxiety as a consequence of that chronic pain. What other symptoms am I missing? Yeah, lots of GI symptoms. What else did I miss? I think that's a pretty nice summary. And then, sorry, Nicole, what was the other part of your question?
I was just curious, do you have any hunch of why some women would have endometriosis and be asymptomatic versus somebody who's symptomatic? And do you think it has something to do with the size of the endometrial lesions, the location of them, the number of them, or just hard to say? It's fun to speculate, though.
Yeah, it's a really interesting question. My answer is not going to be entirely evidence-based because we don't know. And that's just a fact. We don't know why. But there are so many moving pieces with endo, right? There's this immune system dysfunction piece. So we know that, I know both of you are specialists in the space, so you know this very well, but we know that the bulk of the immune system is located in the gut. And not everybody with endometriosis has terrible gut health. So if you're somebody maybe who's got really good genetics from your family members, your gut health is really nice and good, or nice and good, healthy, strong. That was totally grammatically incorrect. Then maybe you're not going to experience as much pain. There's also estrogen dominance, progesterone resistance. Perhaps you're clearing that estrogen through really, really well. And so you're not getting that buildup of inflammatory breakdown products that may be driving a lot of pain and inflammation. So it could be related to that. We know that there's this angiogenesis piece, right? The formation of new blood vessels. Which basically allows endometriosis to proliferate, right? So, you may be set up a little bit better to have a little bit less of that activity happening in your body. You may be, producing a beautiful, healthy supply of progesterone, which we know offsets the effects of estrogen, if you are somebody with endo who's estrogen dominant. I mean, it could be a long list of things. It's really hard to say. I mean, your diet may be setting you up for less inflammation and less pain. But it is a really, really curious question. It's a great question because there is no correlation, or not a strong correlation anyway, between somebody who has advanced stage 4 endo and the degree of pain they experience, right? Like there are some people who are just covered in endometriosis, but would never know because they don't experience those typical symptoms of pain. Or irregular cycles or heavy clotty bleeding. So it's a really good question, and I wish I had a better answer. I just don't. But my guess would be that those hallmarks, they don't act the same way in every person, right? So I just suspect maybe there's a difference in the way that endo is acting in that particular person's body who's maybe not experiencing as much pain. It's hard to say.
Yeah. And that's fine. I kind of figured it was going to be an impossible question because realistically, if somebody wanted to do this research study, right, like I hypothesize that the asymptomatic endometriosis people have this characteristic, you would then have to recruit a buttload of people who are healthy, asymptomatic, healthy normals, in addition to recruiting a bunch of people with symptomatic endometriosis. And like, healthy, normal people oftentimes don't volunteer willy-nilly for research studies where they have to like have laparoscopic surgery and invasive stuff happen. So it's probably a bit tricky to do that research. And just the sheer number of people you would have to recruit for a study like that to make any sense of the data, it's probably difficult / close to impossible to do. But it is interesting to speculate because like you said, if there's some women who are chock full of endometriosis, but they would never know, versus somebody who has, a few of the endometrial lesions and then they're really symptomatic. It's almost like in our world with SIBO, like there are people with small intestinal bacterial overgrowth. They have SIBO, diagnosable, but they're completely asymptomatic versus people with SIBO who are horribly symptomatic. There we go. And it's like, well, maybe it's not the overgrowth driving the symptoms 100%. So like in SIBO, maybe it's the dysbiosis that matters more, and we've been chasing the wrong... I'm going to make up my own thing. We're chasing the wrong turkey up the tree. That's going to be the new one for today's episode. I don't know. I felt inspired. What can I say?
Yeah.
No, I agree with you.
And one thing, too, I want to point out. So I know how you were saying some of the GI symptoms that are associated with endo. And I just want to point this out because you were saying severe bloating, diarrhea, constipation, probably pain, GI pain is in there too. Like all these sort of IBS, SIBO-esque symptoms. And I think of SIBO in particular because I find that people get really intense about their bloating. Like they're like, I have SIBO, I have all this bloating, and I just have to clear this bacteria out. And they get very dead set and hyper-focused on the SIBO side of the equation. And they're not able to see any other potential factors that could be at play in the bloating. And I think with SIBO, the bloating could be a hallmark symptom. But they use the bloating as like a guidepost of, oh, I just like haven't cleared the SIBO out enough, or I need to go harder with treating this IBS, or I need to clear more bacteria out. And it could dig them into a bigger hole if they're not able to see potential other factors. So I like that you listed kind of other symptoms and other things to look out for so that people can really take a step back a little bit. And if working on SIBO and working on their gut side of the equation isn't really pushing the needle at all, that they can look at some of these other potential players in their bloating, like endometriosis.
Yeah. And I wasn't sure if you were going to bring this up as well, but I find with most of my endo patients, I think there's this like misconception that it's endo and only endo driving a lot of these GI symptoms, which is just not the case. That's very, very rare. Endo predisposes us, significantly more than I would say sort of the general sort of normal healthy population to things like SIBO or histamine intolerance or LIBO, gut imbalances, whatever. It predisposes us to a lot of these things because, we have a lot of the risk factors, chronic inflammation, surgery, right, can be a risk factor, high amounts of antibiotic use. And anyway, the list goes on. So that's another thing I'm trying to be a little bit more vocal about, because I think a lot of people, they go, oh, I'm bloated because I have endo and there's nothing I can do about it. But I have never come across somebody who we haven't been able to address the bloat with, because it's not always directly related to endo. It certainly can be if you have significant deep infiltrating endo on your large bowel or your small bowel. Absolutely. There's no question about it. But that's not the case for most people.
And it's so interesting hearing the two of you talk, because like Amy's saying, all of my SIBO people think that the bloating is only SIBO, always SIBO, and they have to treat the SIBO more aggressively. And then you have the exact same problem, but from the endo perspective, where people are hyper-focusing on the endo, and then they're not looking at some of the other stuff. So it's like you both have the same problem that you're describing, but it's in different patient populations. So I hope all those people listen to this damn podcast episode, because we're connecting the dots, people, connecting them. And that actually brought me to a question I had for you, Cindy. Mm-hmm. With, in particular, with the GI symptoms, like bloating, constipation, diarrhea, abdominal pain, if somebody has endometriosis, would you more typically find that those symptoms wax and wane with the menstrual cycle? So they flare up like before or during the period or around ovulation? Or could they be static? Like if somebody has endometriosis and that's one of the drivers of their bloating, for example, might that person be bloated just like 24/7?
That's a really good question. I do see that in some people. So I do see the bloat intensifying a bit more, around ovulation or just before the period, which we know is typically, pretty normal, especially when somebody has like really high estrogen. But I would say most people. So this is something, sorry that I'm kind of going back and forth, but this is something that I pay very close attention to. And so I have found in practice that there are kind of almost like what I describe as gut health types in the endo population. Uh-huh. And so I do pay attention to when they're bloating. But, and what's funny, sorry that I'm like thinking, what's funny is I find that people who have the more cyclical bloating, what I have found in practice is that those are the people that tend to have histamine issues. I'm not really answering your question. I'm just thinking.
No, it is common. And it's totally okay if we ask a question that doesn't really have an answer, or if you're not sure, because I know Amy and I are pretty big on admitting that we don't know all the things, and human beings don't know all the things. We haven't researched everything on planet Earth yet. But yeah, it's curious because like with, and this comes up with my patients sometimes, like with SIBO, for example, I would usually think more along the lines of SIBO if it was someone where they were like, man, I wake up in the morning, no bloating, flat tummy, looks great, feels great, fit into my skinny jeans. And then they eat something with fiber or FODMAPs or carbs, and then they bloat up. And then, like, the bloating gradually diminishes, and then they eat lunch, and then they bloat up again. And it's like that, the timing with the meals, like after mealtime, makes me more suspicious of SIBO typically versus somebody who's just bloated all the time. And like they wake up first thing in the morning and they have bloating right out the gate. So I was curious if endo could be playing a role in that. I mean, theoretically, if the endometriosis is causing adhesions and fibrosis and inflammation, that could be present throughout the entire menstrual cycle or through the entire day, right? So maybe that wouldn't wax and wane quite as much. But it's interesting that you brought up the histamine, because I was going to ask that if you see a lot of histamine issues. It's very much correlated with SIBO and IBS. I see that a lot in our patients as well. But there does seem to be this link between high estrogen and histamine excess or histamine intolerance and mast cell issues. And we know that estrogen generally seems to promote the degranulation of mast cells versus progesterone seems to stabilize the mast cells. So I was actually going to be asking you that at some point, if you've noticed a high prevalence of histamine and mast cell issues.
I do see it a lot. And sorry, just to go back to your other question, I would say there are definitely cyclical changes, but I feel like in practice anyway, if we can address what's driving the bloat and the GI symptoms, then typically we can resolve it. Like, I know a lot of people, I think, we're programmed to think that they're connected, like the endo and the GI symptoms, and they are to a degree indirectly, but yeah, if we address the GI, whatever's, and again, endo predisposes to a lot of these things like SIBO or large intestinal overgrowth as well. And there's actually research about this, right? We know that there's higher amounts of things like E. coli and Staphylococcus and Streptococcus. And so it is something, it is something that's common, but it's nothing that typically can't be addressed. And then in terms of histamine, yes, I do see it a lot just because, again, if there is SIBO present, if there is a large bowel overgrowth present, we know that those things are going to drive histamine. And then, like you mentioned, Nicole, the elevated estrogen not being able to clear it out. These are also going to be drivers of histamine. So I think it's less rare in the endo population than I think the general healthy population. I do see it a lot. I would say for every like maybe 20 people with endo, maybe 3 or 4 have some pretty significant histamine issues. Yeah.
Yeah, it's definitely higher than the general population. And I just had a thought, and again, you might not know the answer to this, or humans might not have researched it yet. I'm kind of curious if the endometrial lesions themselves have a microbiome in and of themselves. Has anybody researched that? Are you familiar? That would be so fascinating.
It's an interesting question. You dig deep. That's a really good question.
Or I just have like a weird brain that thinks of all of these random ass things, one or the other.
No, but it's a good question. So I don't think there's research on it, but we do know that they have a mind of their own in terms of like aromatase activity, for example, right? We've got higher aromatase activity on endometrial-like tissue. We know they tend to be a bit more progesterone. That's where the progesterone resistance is coming. It's coming from that endometrial-like tissue. And they can contribute to that histamine, the overproduction of histamine. And around angiogenesis, so that formation of new blood vessels, we know that endometrial-like tissue, it's got more of that VEGF activity as well. So the production of those the blood vessels. But I don't know about the microbiome. That's a really good question, and I'm hopeful that we do get some research in that space. Yeah.
It would be really fascinating. We just recorded an episode, but we did a total microbial load episode and just brought up the idea that there are these different microbiomes all over the body. So it wouldn't surprise me if the endometrial lesions have their own microbiome in and of themselves. So interesting to think about.
Actually, you know what? Now that I think about it, I think there has been some research done on this, but I'd have to find... I would have to find this this study, actually. I think there has been research done on it. Or maybe that was just in the vaginal microbiome. Anyway, I'll have to look it up.
You could do an Instagram post. We'll inspire you for an Instagram post now. And then that's all the more reason for people to go follow you at endo.fertility.dietitian on Instagram.
And if I find the study, I will send it to you guys, and then you can link it to the show notes. But I'm almost positive there was something. Anyway, I won't waste time looking for it now unless you want me to. But
no, that's all right. But I had another question pop into my brain too. And when we were talking about VEGF and the formation of new blood vessels, that brings to mind, does endometriosis make you more predisposed to cancer? Because increased blood vessel formation and VEGF are associated with different types of cancer.
Yeah, you're so right. That's funny that you bring that up, because I was just thinking about that yesterday. So there is, and this is surprising to me. I don't know that I believe this fully, just based off what we know about endo. Like, we know having elevated estrogen, right, predisposes us to estrogen-dependent cancers. So with that increase in that VEGF activity, I would suspect that there is a higher incidence of ovarian or uterine cancer, but the research doesn't seem to show that. So no association at this time between endo and cancer. But again, I feel like it's just a matter of time before this comes out. Because again, we know that estrogen drives a lot of these gynecological cancers. And this point you're making about the VEGF.
And it could be as simple as, like we were saying before, if there's a subset of women who have endometriosis, but they never get diagnosed, either because they're asymptomatic or because we've normalized period pain to the degree that we have, maybe that's the wild card. Maybe when they're doing these studies, they're looking at healthy normals that actually contain some endometriosis patients and comparing that with the people who have received a diagnosis of endometriosis. So yeah, there might be some confounding variables in the research there, but I was curious when you brought up VEGF, because I know I've seen that in various types of cancers.
Yeah, and then there's the question of, like, my understanding of VEGF is, like, if you have this above average production of VEGF, are you then more responsive to treatments? Right? And then is that what's kind of lowering the incidence of these cancers in people with endo? Like, whether, like not even related to cancer, like if they're doing some kind of hormone suppressing meds, right? I don't know if you get what I'm saying.
I think, yeah, it's like the VEGF could almost be a double-edged sword. Like, it could be doing something kind of vaguely useful, or
exactly.
Like helping kind of prevent the cancer or causing the cancer, depending. And maybe it depends on the location and the tissue that it's in, too.
Sure.
Interesting to chew on.
Yeah.
I'm curious, again, like halfway through the podcast episode, but whatever, it is what it is. That's what we get for winging it here on the IBS Freedom Podcast and keeping it conversational for all of you. But would you mind sharing a little bit about your story? Because obviously, like, you got into this work and working with women with endo because you yourself have it, right? Were you misdiagnosed? Like, how long did it take you to get diagnosed? Like, what was that journey like for you?
Yeah, so I'm one of those people that had an excruciating period from the first one I ever got. So that was pleasant. So 12 years of age, got my period. It was excruciating. I remember that day very clearly. I was in elementary school still, and they had to call my mom to come pick me up because I was in so much pain. And it's funny because, well, without going into too much detail, but I have a family friend who's a bit older than me. She's about 4.5 years older than me. And she made a comment about her period. And I didn't know what it was at the time. So she kind of told me what to expect before I had ever gotten my period. And so I told myself in my mind, like, I talked to my mom about it because I know my mom, she had excruciating periods as well. So I suspect I have it because, you've got a 6-fold likelihood of getting it if somebody, if a woman in your immediate family has endo. So although my mom hasn't been formally diagnosed, but I highly suspect because her periods were extremely, extremely debilitating as well. And so she would share stories with me about herself and how she suffered so much as a young adult. And, but her sister, so my aunt on the other hand, she could do everything. She could run around, she could play soccer, she was very active on her period, no pain, she was living the dream. And I convinced myself that my period was going to be like my aunt's, but unfortunately couldn't quite control that.
Oh no. Yeah.
It's like the embodiment of those damn tampon commercials, where it's like, don't worry about your period, ladies. Get on a horse, go for a swim, play volleyball. You live your life. Like those tampon commercials are borderline obnoxious.
Yeah, I agree.
True.
But you're so right. Yeah, and then the journey began. Like from 14. I remember 14 going to the doctors with my mom, really just trying to figure out what's going on because I was in pain all the time. At one point, I ended up in the ER because I had an extremely painful left lower quadrant pain. Just completely debilitating. 14, went in to see a doctor, older, gray-haired man, who told me that one day when I grow up and get pregnant, my pain will go away. But in the meantime, go on birth control at 14 years of age. My poor mom was confused. We're all just confused. And then I was on birth control for a time. And I did find that helpful for my pain. And it got to a point where my cycle started acting a little bit funky. Like, I started getting breakthrough bleeding and then the pain started returning, and my doctor's response was to put me on a stronger birth control. And at that point, I felt my mental health, declining a lot. I just didn't feel right. Like I was extremely iron deficient. Like there was just some oddness going on at the time. And I just kind of used my logic, as a young adult and said, I don't really think this is working. Like something doesn't feel right. So I came off the birth control, I want to say in like my early 20s. And then, pain of course came back, extremely debilitating. And I just, I kept going to doctors. This is a very common story I think you'll hear from women with endo, just frequent visits. I've had more ultrasounds that I can count, more blood tests that I can count, been followed closely by many doctors. I've been told a lot of false information. Like at one point I had my hormone levels tested and my progesterone in that, in the luteal phase where your progesterone is meant to be very, very high. It was at 4, and the gynecologist was like, oh yeah, you're ovulating, you're fine, you're normal. But turns out I probably wasn't, because it was just so low. And we know that progesterone is like our feel-good hormone, right? It's meant to help us feel good, sleep well, reduce anxiety. And mine was just through the roof. And so that was really disappointing. And when I look back, knowing what I know about endo now, I'm just kind of like, that's terrible doctoring, but whatever. And then I just took matters into my own hands. I started researching. There's so many chronic illnesses out there that respond so well to diet and lifestyle. And so I just took matters into my own hands. I started researching, changed up my diet quite a bit. And then my pain was actually pretty manageable at the point when I had my surgery in 2018. So it took me 15 years actually to get a diagnosis. So it's 28, I think, if that math is correct. And I wanted to so at that point my pain was manageable because I had been managing well with diet and lifestyle, with the exception of pain with intercourse, because it turns out I had like a massive nodule on my cervix. And so I still wanted to pursue the surgery because my husband and I were trying to conceive. And so we wanted to kind of rule out endo maybe as a cause. And for me, it was always about knowing that all this time I wasn't crazy, right? That I wasn't just whatever it might have been, right? So anyway, I had the surgery in 2018. Turns out I had endo. It was quite significant. Left abdominal wall, bladder, cervix. I had my appendix removed. So it was quite significant. And it didn't really make a difference to my pain. I have found that, the most effective strategy for me personally has been diet and lifestyle modification. I know that everybody has different ways that they like to manage. And yeah, that brings us to today. So not on any kind of hormones. I went through the procedure that I go through with my clients on myself. So sorting out my gut health, because at one point I was bloated like crazy, like from morning till night. It was extremely painful, persistent, chronic constipation at one point. So sorting through all that really helped. At one point, my prolactin was really elevated, and I think a lot of people don't think to check that. That's really important, because if the prolactin's too high, it might prevent you from ovulating or weaken the ovulation, and then the progesterone will be very low, and then that just kind of, you run the risk of having your estrogen dominant symptoms, being extremely, extremely severe. And so I've gone through the ringer, and that brings me to where I am today. So, but what I do know as somebody managing with diet and lifestyle is you have to remain consistent. The second that you make a less than ideal choice with endo, then that pain can come creeping right back and, become extremely painful. So that's my story.
Yeah. Awesome. And I think I'm really glad you were able to share your story, because I think so many people will be able to relate. Even if they don't have endo, I feel like there's so many people out there with chronic conditions that have just been sort of undiagnosed, and poor doctoring, as you were saying, is just so common, unfortunately, when you're having a 5 to 10 minute appointment. And they have to make very snap judgments about things. But I'm curious too, in terms of diagnosing, or again, getting a diagnosis, is there like screening that you do, or how would you screen for endometriosis, and then how would you go about like getting an actual diagnosis? What does that look like when it goes well, when there is good doctoring? What would you advise someone to do if they were suspicious that they might have endo going on?
Yeah, so my advice would be to, hop on a search engine and look up endometriosis specialists in your area, or somebody that's, relatively close to you, and request a referral immediately, because you're going to get tossed back and forth between specialists and all these like unnecessary tests. And it's so mentally draining, right? So that's my suggestion. And then, if it is a good doctor, if it is somebody who's a specialist, they really should get you in for surgery. So a diagnostic laparoscopy with excision is the best way to, the diagnostic laparoscopy would be the best way to get diagnosed, and then excision is the gold standard treatment option, or management option, management option. And there are some specialists and surgeons, worldwide. So the one that we have closest to us here in Canada would be Dr. Matthew Leonardi out of, I believe he's in Hamilton. Anyway, and he is also very skilled in advanced ultrasound. So somebody who has that skill, if it is, deep infiltrating endo or something that will show up on the ultrasound, they have the skills to diagnose that way, which I think is an incredibly useful technology, because why, cut somebody open and explore? I mean, it on the scale of surgeries, like the laparoscopy is not the most invasive, right? There are significantly more invasive surgeries, but you still, like, I still have clients who develop SIBO after laparoscopy, right? Like there's still risks associated with having laparoscopy. So I think it's a much needed technology, because they can tell you already, even before they go into surgery, where your endo is located, how severe it is, any specific prep instruction, or any kind of, proactive management suggestions following surgery. If the patient decided to pursue that, like, you can plan for risks in that case. So I think it's such an important, necessary technology, and I'm hopeful that more and more specialists will get training in that. But currently, so few people are doing this worldwide. So those would be the two ways to get diagnosed. And with the amount of people who have endo, the amount of surgeons available to us it's sad. It's so sad. Which is why I think that statistic isn't partially why that statistic isn't higher, right? Because we just don't have access to diagnosis.
Yeah, that makes sense. That's a good point too. And you answered one of my questions before I even got to ask it, which is great. I was going to ask, like, could we just refer somebody out for an ultrasound, like, of the abdomen or, transvaginal ultrasound or something like that. But it sounds like unless the person is really, really skilled at looking for endometriosis specifically, that probably like a run-of-the-mill, wake radiology here, like if I just sent somebody for a run-of-the-mill ultrasound, it sounds like it's probably not going to be enough to diagnose endo, right?
Right. And, there are some stories that I hear, like even from people that I work with closely, like they've even had surgeries done where the person wasn't specialized and they completely missed the endometriosis. So even having cut open and gone into the patient, they weren't able to find the endo. And so, because if you think, like, Nicole, you may know this better as a doctor, but like, I guess there is an appearance to it. And some of the endometrial-like tissue is, I guess it can be easily camouflaged, is my understanding, right? Like, I'm not a surgeon, but it can kind of blend into the tissue very well. So even the tiniest of little pieces can cause somebody excruciating pain. But if you're not well trained, if you don't know what to look for, how to look for it, then you can even miss it on something like that. So yes, you do need to be well trained. You do need to see a well-trained surgeon. I know for people who don't have access to this support, to these services, sometimes they do settle for somebody who doesn't do the gold standard procedure. Things are missed. Some of them are still doing ablation, burning the tissue, and then that can introduce, a whole other additional layer of inflammation. A lot of people experience more intense symptoms after ablation, right, which is the burning away as opposed to cutting away the tissue. So, yeah, it's a great point and a great question, which is why I think we need to be talking about endo more, right? Because even when it comes to the management options available, those are lacking quite a bit too in expertise and access. So, yeah.
Well, and I know a lot of people, certainly that we've worked with, a lot of people are becoming very distrusting of conventional medicine. And they're wanting to pursue things other than drugs and surgery. So that segues beautifully into, like, this, obviously, there would be a lot of context for the individual person and their root causes and their comorbidities. But if somebody just like walked up to you on the street and said, "Hey, I know you specialize in helping people with endo. You have 3 minutes to tell me something useful. Like, what should I do? I was just diagnosed." Like, are there any, like, bullet points or things that you think are nearly universally useful? Like, I know on Instagram, I think I've seen you preaching the good word of the magnesium and the fish oil, for example. Do you think that those are almost universally useful for people with endometriosis as an easy starter?
I think because, the food supply is so depleted in magnesium, and we know that a lot of stress, whether it's coming from chronic inflammation or, overstimulation of the adrenals or under eating or over exercising or not getting in enough nutrition with endo, I do think magnesium is, is one of those nutrients that I think everybody could benefit from. I don't know how much both of you are into like functional medicine testing and like HTMA, if that's something that you like to do or like to look at, but all of our
into it. Go ahead.
Well, yeah, no, I mean there's still some parts of the HTMA that certainly are need a lot more research for sure, but something that we've understood for.
Sorry to totally derail you. Can you just translate for people what HTMA is, just in case they don't know what that acronym is?
Yeah, sure. Hair tissue mineral analysis.
There you go. Okay, continue.
So it's like a hair collection, right? So, what was I going to say? So, I mean, whether you do hair tissue mineral analysis testing or not, we know there is this understanding. I mean, we've had this science for a really long time that all of our minerals interact, right? There's some kind of interaction, vitamin C and vitamin D and vitamin K, right? Or vitamin E and vitamin C, or iron and vitamin C, and how they kind of support each other with absorption. Calcium and magnesium is another one, right? So they kind of do opposite things, or I should say rather vitamin D. If we're over supplementing or getting too much vitamin D, it will move a lot of that calcium and magnesium out of the tissue, right? So that's just one example, but our minerals interact in so many other ways. So where I was going with this is, I do think for most people it is safe to supplement magnesium, just because I have seen in practice most people are depleted in magnesium. And again, we're predisposed to a lot of those drivers, right? Like inflammation, chronic inflammation, under eating, right? Undernourishing. These things will increase somebody's need for magnesium. So I do agree with that one, Nicole. I think supplementing magnesium, can be helpful, but then there's also a few types of magnesium. So picking the right one for you will be very impactful, right? So if you're struggling to have a daily bowel movement, then you may consider something like magnesium citrate, or magnesium glycinate if you're somebody who has trouble sleeping or needs some more support relaxing. So I do agree with that one. And fish oils, yeah. So one thing that I like to talk about is optimizing that omega-6 to 3 ratio, right? I don't know how accurate the statistic is these days, but I remember reading back when I was doing my dietitian training that the omega-6 to 3 ratio could be as high in some parts of the Western world as like 40 to 1. I think it's probably closer to like 10 to 1-ish now. But omega-6s are so much more available in the diet, right? Like if you're consuming a lot of processed foods, if you're relying on a lot of fast foods, you're using vegetable oils, like it's a lot more available as opposed to omega-3s, which we largely find in our oily fish, right? And, fortified foods and things like that. So, as dietitians, I feel like, maybe Amy can relate to this, but like we always want to food first, right? Food first approach, but you have to be diligent about getting those like 2 to 3 servings of oily fish in per week. If you're not, then certainly, yes, I do think that those omega-3 supplements can be helpful, particularly in somebody with endo, because you are dealing with more inflammation. And one thing that I do like to focus on is what is all, driving that inflammation, right? Where can we reduce inflammation coming in, right? Whether that's, focusing on cooking methods so that we're not, introducing more ages, advanced glycation end products, which will contribute to inflammation, right? And DNA damage. Are you clearing through your estrogen well, right? Because if we don't, then again, those breakdown products, those metabolites of the estrogens that we produce will build up and be a source of inflammation as well. Pathogens. So do you have something going on in the gut? Do you have SIBO? Do you have a parasite? Do you have something in the gut that's driving inflammation? Toxins from our beauty products. Anyway, the list goes on. So anywhere that we can reduce that inflammation, including from the diet, optimizing that omega-6 to 3 ratio, I do think is impactful for everyone. Absolutely. And I think, one of the things I find, I guess I should say 2 of the things that I find most impactful for supporting improvements in pain would be getting sufficient protein in. I think a lot of people don't realize how important that is. I mean, protein is needed for so many different systems in the body, including, stomach acid production and enzymes, all of our enzymes, right? We need those to help. I mean, it's a really complicated conversation, but there's so many enzymes in the body that do so many different things. But the one thing that comes to mind is like the enzymes that are needed to break down our food, right? Our macronutrients, our proteins, carbohydrates, and fats. So if we're not getting in enough protein for that reason, or for wound healing, or for digestion, then a lot of those systems are going to struggle, right? And we really want to support those systems as much as we can with endo, right? We want to maximize nutrient absorption. Anyway, where am I going with this? So getting in enough protein is a big one. And then the other one would be, what was the other one I was thinking? Getting in enough protein, and I think what I was thinking was gut healing. So usually the one place I'll start with my clients is the gut. So if they have any kind of GI symptoms, whether, that's reflux or that severe painful bloating or inconsistent bowel movements, chronic constipation or chronic diarrhea, I have found consistently, that when those things are addressed, the pain levels significantly come down. And that makes sense, right? It makes sense. I mean, that's one of the way that we clear through toxins, things that we want to remove from the body. And again, because there's that immune system dysfunction piece in endo, right? And to simplify that, I guess, for your listeners. So in a healthy person without endometriosis, if the body got that trigger that there's this endometrial-like tissue looking to kind of establish itself somewhere in the abdomen, a healthy person's immune system would come in, attack that tissue, get rid of it, so it doesn't have the opportunity to kind of root itself and then begin proliferating. And somebody with endo, your immune system springs into action, but let's say hypothetically it only works at about, 80% capacity. So that 20% deficit is where that tissue is able to kind of establish and then proliferate, right? And so the better we can get that immune system functioning, right? And we know that the bulk of it is located in the gut, i.e. improving that gut health, the better you'll set yourself up for the future and supporting improvements in symptoms and slowing proliferation and that sort of thing.
Yeah. Yeah, I think those are really good points. And if you think about it too, it's sometimes the weird thing about this world is that it's the most unglamorous, unsexy stuff that gets you the furthest. I think also there's this, a lot of people have this desire, rightfully so, but they'll be like, my case is so special or so severe or so unique that I need super specific, tailored stuff just for me, not for anybody else. And we kind of get down on the idea of a protocol or a template. And it's not to say that that's always a bad thing. I think optimizing omega-3/6 ratio, making sure you have enough magnesium, making sure you're getting enough protein, healthy fat, fiber, healing your gut if you have gut stuff going on. Those, ironically, could be great things to tell anybody with any diagnosis. Oh, you have heart disease, do those things. You have, you've had a stroke, do those things. And stress management and making sure that you're sleeping enough. These are really unglamorous sounding things that sound like, oh, they're too generic to help me because I'm special. But honest to God, they help people with all sorts of different diagnoses and symptoms and afflictions. And if you're not tending to those, there's no amount of custom blended tinctures or fancy schmancy antimicrobials that are going to pull you out of this rut if you are blatantly magnesium deficient, or if your omega-3/6 ratio is 40-1 or whatever it was that you read. That's horrifying. So
yeah, I mean, maybe that's a bit of an exaggeration, but no, I totally agree with you. It is the simple stuff, right? For sure. And I always find, it's funny, my content about supplements and stuff on Instagram does so well because everybody just wants to throw some supplements into the mix but I mean, you're so right. It ultimately comes down to doing the simple things and doing them well. I do think that people with endo are, disadvantaged quite a bit. So it makes those simple things, I guess, harder to improve. But no, you're so right. I mean, it absolutely, it is the simple stuff, and the simple stuff will make a difference in symptoms for sure.
Yeah. It's the foundations are foundational for a reason, right?
Absolutely. Yeah, you're so right, for sure. Yeah. I don't know what else to say about that.
Yeah, I had one other question too. So I know surgery sounds like a bigger part of the treatment side of things for endo. I'm curious, and I'd imagine that if you had surgery, you really want to prioritize doing all the stuff you're recommending post-surgery and pre-surgery too, but you want to really get lifestyle, diet, any sort of necessary supplements honed in on post-surgery to prevent things from coming back. But I'm just curious about what's kind of is there a rate of relapse or something from surgeries? I'm not familiar with how that would work, but I'd imagine that that doing some of the stuff you're describing prevents relapse, because you're lowering inflammation and lowering potential endo from coming back. But I was just curious about that. Do people do multiple surgeries, or how does it typically work?
And I have a piggyback question real quick before you answer. If you get an endometrial lesion removed, can it grow back? Is that a thing that happens?
You know,
Don't we know?
And the thing with endo is like, this is why we need to talk about it more, right? There's so much we don't know, but the recurrence rate, again, this is a statistic that I'm like scratching my head about a little bit, but it's said that for excision, if it's done well, the recurrence rate is something like 5 to 10% within 5 years. I think it's a lot higher than that, in my opinion, just based off what I'm seeing in practice. And I mean, like, what does that mean? Like a good surgeon? I mean, I don't know. Again, this tissue is hard to see, even for a professional, even for a specialist, even for somebody who's been doing this for so long. But anyway, that's a statistic there for excision. And then for ablation, it's significantly higher. I think it could be up to about 60% within 2 years. So it does come back. Yes, a tissue that's been excised. It really depends on, like, if its root has been removed, right? And I'm not a surgeon, so I find this a little bit harder to answer. But logically, if the root's removed, it's probably not the exact same one that's growing back, but it doesn't prevent you from having new endometrial-like tissue, emerging maybe in a different place, right? So I imagine the same tissue wouldn't grow back, but it doesn't prevent you from having like regrowth elsewhere. So the recurrence rate is quite high, unfortunately.
But that's such an interesting. But I did want to say that's a really interesting point about like ablation versus like cutting the lesion out. I had never heard kind of the differences between those two options, so that's really helpful to know.
And I mean, I was just going to say, like, if you're burning away, and again, I've seen this in practice quite often, most of these people, and not all, so if you're somebody who's listening to this and your doctor's kind of scheduled you in for ablation, not everybody experiences this, but it is common to see that the pain actually gets a bit more severe because you're burning. So you're creating quite a bit more inflammation, right? You're creating scar tissue. So we do have to be mindful of what that does to the body as well. But again, same idea with excision, right? You're cutting. So at least with excision, you're cutting away, the endometrial-like tissue, but it's very hard to answer these kind of direct questions because there are so many different things with endo, right? This goes back to Nicole's previous question about why some people get pain and why some people don't, depend, like irrelevant from whether they have, more advanced endo or not. Again, because there's so many things at play. There's also the whole genetic component with endometriosis, right? Like a lot of people with endo were predisposed to genetic mutations that, prevent how well we clear estrogen through the body or how well we transform inactive vitamin A into retinol or conversion of inactive vitamin D from the sun to the active form that can be used by the body, right? So, and we're predisposed to those genetic mutations. So there is just an extensive amount of information that we need to be mindful of when supporting somebody with endo. So it's not, unfortunately, like I wish I could give such a simple answer to these questions, but it depends. I do believe though that if somebody goes and gets surgery and comprehensively supports their body, so, is basically to the point where they don't have GI symptoms anymore, or at least they're mild or considered normal, maybe has done something like Dutch testing to see how well they're methylating or clearing that estrogen through the liver. If they're, assessing for heavy metals, assessing for copper, right? If the copper's too high, your body won't be able to get rid of that estrogen, right? So looking at that, maybe considering doing some genetic testing to see if you're exposed to that or predisposed or have that MTHFR gene mutation or the COMT gene mutation, which, for your listeners are genetic mutations that, without going in, I guess, into too much detail, can cause inflammation, can contribute to pain and inflammation and other symptoms of endo. So looking at those things, anyway, there's a long list of things. Looking at, I think I was just finishing off there, looking at the potential for genetic mutations, looking at exposure to heavy metals. Like if you have a lot of mercury or aluminum from antacids or use of aluminum foil, like all these things can contribute to GI symptoms as well as you first walking by or pain and inflammation, right? Went off on a bit of a tangent there.
No, but it's good because it builds this world, right? Of, again, it's not like there's one magic herb or one magic vitamin for all of endometriosis, because it's going to depend if the person has endometriosis and also SIBO, or if they also have histamine issues or estrogen issues or methylation issues or detoxification issues, or if they have certain SNPs, or, whatever the case may be, candida, leaky gut. You really got to take the totality of the case into consideration.
Exactly.
At least, still do the foundations. Again, they're foundational for a reason. But when you want to move into more specific stuff, that's where getting some more advanced testing or, having a team around you to help support you and help you understand what's going on becomes so, so helpful.
Yeah. And then there's this big question, and this is rare, but I have also seen this in practice where somebody's doing everything right. They're doing all the testing. We're supporting all the systems, and the pain is still debilitating, right? There's this huge question there. That's the other end of the spectrum. So I don't ever want anybody with endo to feel like it's their fault or they're doing something wrong. It's not the case. This disease has a mind of its own, and sometimes we just simply can't make sense of it.
Well, and again, I think that goes to show us that, again, we don't know everything about the human body. We don't know everything about endo. We don't know everything about SIBO. Like, scientists are going to continue discovering things every single day for the rest of our lives, and hopefully many, many years beyond that. So hopefully somewhere someone finds answers to all these questions. But until then, we get to speculate and hypothesize and just try to help people with the tools that we have available, right?
Yeah, exactly. Well said.
All right. Well, Amy, I don't know if you have any more questions or not, but I feel like my brain is mostly tapped out at this point. I feel like so far so good. I think, Cindy, you answered most every question that I had on my radar. Do you have any closing remarks, or is that right about where we want to wrap up? Because, like I said, I can't think of anything else in my brain at the moment.
No, just, if you are somebody who's listening and you have endo or suspect endo, know that, it's not like a death sentence, for lack of a better phrase, I guess. There are things you can do to support your body. Go into your appointments well informed. I have a blog post on 20 odd questions you can ask your surgeon or your doctor. Birth control isn't the only option. There are other things you can do, and you're not alone in your struggle with endometriosis. And that's, I think that's the take-home message, is it can feel very lonely and very scary, but there are things that you can do to support yourself. And I think that's the take-home message that I wanted to share.
Yeah. And that was a beautiful way to wrap up, because, if you're listening and you have endometriosis, you're not alone. There are things that can be done, and hopefully this podcast episode lit up something in your brain and gave you something that you can work on now. And if not, you have, according to Instagram, which apparently is a creepy creeper, you have 460 Instagram posts on your wall, or whatever it's called, as of the recording of this episode. So for goodness sakes, if anybody's listening and you're like, gosh, I want to learn more from Cindy, she sounds awesome. A, I would agree with you, but B, check out endo.fertility.dietitian on the gram, and I will surely do a shout out when this episode drops, and we'll see if we can't get people to your Instagram who need this info the most, because we didn't cover the totality of all of endometriosis in today's episode. But again, hopefully it lit up something in your brain. You had a spark, you had a light bulb moment, and you can have many more from those 460 some odd Instagram posts that Cindy has. So as always, guys, thank you so much for tuning in for the IBS Freedom Podcast. As always, we will see you in the next episode. Take care.